This is an old-fashioned fluoroscope. This is from 1925. And this is the actual fluorescent screen. The X-ray tube is back here. This is on cables, and the radiologist would stand in front of this and hold it in his hands and then move it up and down in front of the patient. I don't want to embarrass anyone, but has anybody worked with something like this in their lifetime? Yes? You've been in one of those. I was telling Nat, I actually have one of these fluorescent screens, and I wanted to bring it, but the thing has leaded glass on it, and it weighs about 50 pounds. So I didn't bring it with me, but and there's a museum in Albuquerque, New Mexico, where they actually have this that you can go and look at. But this is an old fluoroscope, and of course radiologists at one time had a higher incidence of leukemia from all of the exposure that they received, mostly during fluoroscopy, when they'd stand out in the room in front of this fluorescent screen, and they were basically the primary barrier for the radiation coming through. Now let's talk quickly, and just a quick review of X-ray production and what it is. Well, Einstein got his first Nobel Prize for his discovery of photoelectric effect with X-ray. And we'll talk about photoelectric effect and what it is. But when we make X-rays, we've kind of used this law of relativity here. E equals mc squared, where energy in the form of electromagnetic energy, X-rays, are created by accelerating mass, which is an electron, at the speed of light in a vacuum tube. Now, what do we do how do we accelerate that? How do we get those electrons traveling from the cathode to the anode, a cathode ray tube, at the speed of light? We do it with voltage. Okay? Some of you may have been around X-ray enough to know that we use KVP, kilovoltage, and MA, milliamperes, to create X-rays, or to produce X-rays. So this is a modern X-ray tube. They're making them out of metal now because the glass tends to get too hot and crack. And the anode, which is here, is the receptor of the electrons. This is the cathode. So you have a cathode, which is negatively charged, an anode, which is positively charged. We have a source of electrons, which is a filament that's right here. And we heat this tube, heat the filament up with current, with electrons, and then we accelerate the electrons with voltage, thousands of volts, from the cathode to the anode. And when the electrons strike the anode, they produce electromagnetic radiation in the form of X-rays. Now, as I said before, this process isn't very efficient. 99% of the energy is heat. About 1% of the energy is actual X-ray production. So this is a typical X-ray tube, just the parts of it. The anode itself rotates, it spins at about 4,000 RPM because you have to dissipate the heat somehow. You can have stationary anodes, but they don't last as long. So most high heat capacity tubes is spins. And then this is the cathode where the filament is. And there's actually two separate circuits. One that produces high voltage. We have step-up transformers that do that. And then one that produces low voltage and high amperes to heat the filament up. The problem with the older tubes, back in Rinken's day, is by the time you stepped your voltage up high enough that you could produce X-rays, you didn't have enough current left over. You step your voltage up 1,000 times, your current is going to decrease 1,000 times, and that's why we use KVP and MA, milliamperes. Whereas a normal circuit runs on volts and amps, right? And resistance. So this is a typical X-ray machine. We call it a diode tube because it has a cathode and an anode. It's also a vacuum tube. We suck all the air out of it to improve the efficiency of the X-ray production. Because we're accelerating electrons, we don't want them to interact with anything except the target. Okay, so what happens is we use current to heat up a filament. The filament emits electrons. We call this thermionic emission. And then the electrons are accelerated from the cathode to the anode with voltage. And we use step-up transformers to change the volts, 110 volts out of the wall, into thousands of volts. So these step-up transformers change voltage to kilovoltage. Why do we need kilovoltage? To produce high energy, high acceleration of the electrons so that we can actually make the X-rays. Otherwise, we'd be making microwaves or other things. I mean, we use cathode ray tubes to make all kinds of electromagnetic radiation, including light. But we're just using this to create X-rays. So in an X-ray circuit, in an X-ray machine, there's two circuits. If I'm going to take an X-ray, I have to decide how much voltage I'm going to give a person, how much kilovoltage, I'll set that, and then how much amperage I'll give a person. Now the kilovoltage, the higher the KVP is, the shorter the wavelengths are going to be. The shorter the wavelengths are going to be, the more penetrating they are. If I was going to do a mammogram on a woman, I wouldn't use the same kilovoltage as I would for a chest x-ray or for an abdomen. If I was going to do a mammogram on somebody, I would use anywhere between 20 and 30 kVp. Why? That's a very soft beam. Chest x-ray, we use 110 to 125 kVp, more penetrating. The breast is made out of what? Fat. And there's a little glandular tissue in there as well. Yeah. But, and if you have a lot of glandular tissue and very little fat, they say you have what? Dense breasts, right? Okay, so the breast is made out of, there's not a lot of density in the breast. It's made out of very soft tissue. Well, in order to see an x-ray, in order to see an image, you have to have something called differential absorption. The parts of the body have to absorb different amounts of radiation. That gives us something called contrast. Contrast is the difference between black and white. The energy of the x-ray beam, how penetrating it is, how much of it can be absorbed based on the energy, is determined by your KVP. So KVP controls the contrast of the image that we're dealing with. When I do a chest x-ray, I want a long scale of contrast, meaning I want lots of grays. I don't want to see the ribs, I want to see the tissue underneath the rib. I want to see the lung and the heart and the great vessels. So you've got to penetrate, or what a rude term to use is burn through. You've got to burn through the ribs, not only the front ribs but the back ribs, to see the tissue underneath. So we use very high KVP. When we use high KVP, we use a very low mass. Mass is my number of electrons actually flowing, right? The quantity of radiation. So since I have so many electrons that are going to go through the patient, I don't need as many of them, or photons, I don't need as many of them as I would with a lower KVP where more of them will be absorbed. So when you talk about mammography, I'm only using 25 KVP. What do you think is happening with the mass? Is it going to be high or low? High. Mass is the number of electrons flowing through the X-ray tube. Why do I need more mass when I do a mammogram? Because more of them are going to be absorbed by the patient. They have to be absorbed to give me contrast on the film. So mammography, unfortunately, has a higher dose than most X-rays because we have to use such low KVP to get the differential absorption to produce the contrast to see the breast tissue. Okay, so there tends to be higher mass with a mammogram than there is with a chest X-ray. A higher dose rate for that. We'll talk about that more later. But what I want you to understand right now is in the X-ray tube, we have the KVP, which controls the force with which the electrons go from the cathode to the anode. That's going to control the wavelength and frequency, or the quality of the X-ray beam. And then we have the filament, which has current flowing through it, and that sets the mass, the quantity of actual photons that I'm going to make in my beam. So if I'm doing an X-ray on someone, or an examination on somebody, and I have two people, and I'm going to take a chest X-ray on them. Let's say one person weighs 400 pounds and the other person weighs 90 pounds. Well, if they're not diseased, okay, they don't have emphysema, they don't have congestive heart failure, then they should have exactly the same material within them, right? Except one has more fat or muscle and the other person is thinner. So the KVP, as far as penetrating ability in my contrast, I'll keep that the same. What I'll change is the quantity of radiation going through the patient. Because the thicker someone is, the more radiation they're going to absorb. Doesn't matter if the KVP is the same or not. If somebody's half the size, you need half the quantity to go through them. So on one patient that's 400 pounds, I might use 10 mass, and on the other person who's 90 pounds, 2 mass, but 110 KVP. So KVP controls the energy of your beam, and mass controls the quantity of your beam. That's going to give us different results on a radiograph or on a fluoroscope, whatever you're using. So the filament tends to be high current running through the filament, and then the tube circuit has high KVP. So again, KVP, when we talk about the quality and the quantity, KVP controls the quality of your X-ray beam, how penetrating it's going to be, how much of it will be differentially absorbed in the patient, whereas mass, MA, which is your current times the amount of exposure you give a person, the amount of time, milliamperage times seconds. This is the actual number of X-ray photons that make up your beam. Now, these two things control two different parts of your image. Density, the definition of density is the overall darkening or blackening of your image. Okay? Density is a black area on the film. Density is primarily controlled by your MA, or by your mass. Okay? The more photons I have in my beam, the darker the film will be. All right? Whereas contrast, the difference between black and white, is controlled by your KVP. Contrast, or KVP, is going to control how much radiation will be absorbed in the body. If I increase my KVP, more of the radiation will go through the patient. There will be less differential absorption. If I decrease my KVP, as in a mammogram, there will be more differential absorption and the contrast will be greater. I always like to think of contrast as white and density as black. The only way you're going to get white areas on your film is if the patient absorbs the radiation, right? Okay, differential absorption. Or if you give the patient a contrast medium, like, what's an example of a contrast medium? Barium. Barium has a very high atomic number, about 4 times greater than bone. And so when X-ray interacts with it, it can't get through it, it's heavy, interacts with it, it's absorbed, and that gives us a white area on a film. We use contrast agents for parts of the body that have poor subject contrast, like a stomach, hollow organs. They can't absorb the X-ray, it goes straight through them. So if we want to see those things, put a contrast agent inside of the patient and they'll get differential absorption and we'll be able to see it. Okay, so KVP controls our contrast, and this is considered to be high contrast, black and white, or a short scale, and this is low contrast, gray. Okay, so with high contrast, am I using high or low KVP to get high contrast? Low. Low KVP. Why? The lower the KVP, the more X-ray the patient can absorb. The higher the KVP, the shorter the wavelengths, the higher the energy, the more X-ray goes through the patient. So for a chest X-ray, for example, 110 KVP. Most chest X-rays, we like them to be gray. We like a long scale of contrast, a lot of gray on there. You need high KVP to penetrate through the denser areas of the body. With a mammogram, we want them to be black and white, right? You don't want a gray mammogram. You want it to be black and white. You want to be able to see the microcalcifications in there. We have to use very low KVP so that the patient has the opportunity to absorb the radiation. Okay, so when we talk about the controlling factors of the quality, the optical density, the darkening of the film, is controlled by your mass, or your MA times your time of exposure. The contrast, how white and black the image will be. Short scale of contrast means black and white. Long scale of contrast means more grays, more differential. That's controlled by your KVP. And then we have other things that we talk about, recorded detail, how sharp the image is. That has to do with our focal spot. And then distortion, that has to do with whether a part is elongated or foreshortened. And that usually has to do with the relationship of the primary X-ray beam with the patient. If the beam is angled, you get an elongation look that you'd see like on a Townes skull X-ray or a Waters view. Okay, if the beam is angled, if the part is angled, you're going to get foreshortening of the part. So a little bit of distortion that we can use to our advantage, usually to separate overlying structures. Okay, now that we have X-rays and they're created, we can control the energy, right? The KVP controls the energy of these X-rays, or what we call the quality of the beam. And then we have mass that controls the actual quantity, how many photons we're producing. Now, mass is directly proportional to dose. As I increase my mass, I increase the number of photons that are in the beam, and I increase the dose to the patient. There's more X-ray to interact with the patient. KVP, on the other hand, is inversely proportional to dose. Why? If I increase my KVP, does the patient absorb the radiation? No, it goes straight through them. So there's less opportunity to absorb the radiation. Now, what does that do to my contrast, though? Decreases the contrast, right? Why don't we just use 110 KVP for everybody? Because we wouldn't have any contrast on our images. We wouldn't have any differential absorption. So we try to balance the two, use the optimum KVP. We always try to give the highest KVP possible so that the X-ray will go through the patient, but then have differential absorption so that we can see whatever it is we want to see. There's a total difference between doing a chest X-ray and doing a rib series, right? We're X-raying the exact same part of the body. In chest X-ray, you barely notice the ribs. And on a rib series, the ribs jump out at you because the film is black and white, high contrast. If you do a chest X-ray, again, 110 KVP, 3 mass, rib series, 70 KVP, 30 mass. Lower KVP, more mass to get the density on the film. Does that make sense? Now, what about the poor patient? Or what about the patient? When the X-rays are interacting with the patient, several things can happen. What we like to happen, ideally, is either the X-ray is absorbed by the patient or the X-ray passes through the patient. That gives us high contrast. If the X-ray is absorbed, that's an area on the image receptor that will be white. If the X-ray goes through, that's an area on the image receptor that will be black. Okay? Black and white is contrast. Well, that doesn't always happen. Unfortunately, we have tissue in us, we have atoms, we have molecules, and the X-rays are very small, and they interact with those molecules. Now, they can interact, there's like 5 different ways. I'm only going to cover 3 ways with you today because that's really all you need to know. But the way that they interact with the patient is either they'll go through the patient without ionizing the patient, but as they pass through the patient, they produce heat, like a microwave does. Does a microwave ionize your food? No, it just heats it up, it excites it. Okay? So the only difference between an excited molecule and an unexcited molecule is vibration. So when the X-ray passes through, this happens in mammography a lot, lower than 30 kVp, we produce coherent scattered radiation. The X-ray passes through the atoms get excited, they vibrate, they absorb the energy, and then they release the energy as they decrease in their excitement. As they relax, they release the energy, but the energy changes direction. So the fact that the X-ray has been absorbed and then released in a different direction, we call it scattered radiation. Scattered radiation. So it started out going one direction, and now it's going to leave the body in another direction. But the beautiful thing about coherent radiation, no harm to the patient. There's no ionization that takes place. It's simply heat. So it heats up the atom, and then it changes direction. This isn't actually an example. That's paraproduction. I just put it there for... So this is coherent interaction. This is one X-ray photon. This is showing you the wavelength of the photon here and frequency. And the atom becomes excited, it absorbs the radiation, and then releases the same photon in a different direction. It releases the energy. So no ionization takes place to the patient, no harm to the patient, no change in the molecular structure. It's just heat. This particular type of radiation, though, is harmful both to the patient and to you as an operator. And this is called Compton scattered radiation. This is the reason we wear lead aprons, because when the X-ray passes through the patient, if it hits one of the outer shell electrons, which are more loosely bound than the inner shell electron, when it hits the electron, it will ionize the atom, meaning that it's going to knock this electron out of its orbit, but as it's doing something, as it interacts with it, it will change direction. Okay? So if we're aiming the X-ray to the table to go through the patient, it hits something and now it bounces out of the patient in a different direction. Now the problem is, let's say I'm using 110 kVp. This is a photon that has a lot of energy. It hit an outer shell electron. It took a very small amount of energy to knock that electron out of its orbit. So the photon that's coming out of the patient still has what? Still has a lot of energy, right? It has enough energy to hit you and be absorbed by you now. Okay? So when we're standing in a room with the patient doing fluoroscopic exam or something like that using high KVP, we're getting our exposure from the patient. Okay? Even though that's the person you're trying to help, stay away from the patient. That's your source of scattered radiation. We call it Compton scattered. And the higher the KVP, the more Compton scattered you're going to have. The greater the Compton scattered will be. Some people refer to it as backscattered. Have you heard that term, backscattered? That's and the greatest amount is going to be produced in the same direction that it's coming from. So if you're standing by the X-ray tube and the X-ray is going through the patient, most of the scatter radiation is going to be coming back at you at higher KVPs. 120 to 130 degrees is the greatest area of backscattered radiation from a patient. Okay, the next type of radiation interaction is photoelectric effect. And I talked a little bit about this earlier. And this is when the X-ray photon interacts with the inner shell electrons of an atom. And the higher the atomic number of the atom, like barium, for example, the stronger the binding energy of the K shell and the L shell in the atom that we're dealing with. So atoms like bone, the cortex of a bone, these high inner shells, the photon will hit the inner shell, and when it hits the inner shell and knocks the electron out of its orbit, all of the energy of the photon is absorbed in that interaction. So what happens to the photon? It's gone. It's lost all of its energy by knocking the electron out of its orbit. That will result in what kind of an image on the film? Black or white? White. Photoelectric effect, we strive for photoelectric effect. We want the film to be either black or white. unless we're doing a chest x-ray, and then we want a longer scale of contrast. But for the most part, we set our KVP so that the x-ray will either be absorbed by the patient, giving us contrast, white, or go through the patient, giving us black. And really, if you set the proper KVP, it's a random event where the photon will hit, whether it hits an outer shell and produces a scattered photon, whether it goes straight through the patient and ends up on the film, or whether it hits the inner shell and is absorbed. But for the most part, we are air. If you look at an atom and the nucleus was the size of a baseball, that K shell is a whole mile away. Okay? So the majority of the X-ray will pass through us. But the thicker the part is, the more interaction you're going to have, the more absorption you're going to have. So we call that K-edge of the atomic structure that we're looking at, or of the material. This is an example of barium in an upper GI study. Believe it or not, that's a stomach. This is an obstruction. But the K-edge, when the atomic mass of an element, like barium or iodine is another example that we use these things with high atomic number. Barium has an atomic number of 56, so the K shell has a higher binding energy. Also, it's very dense. If you pick up a jug of barium compared to a jug of water, barium weighs about, 3-4 times more. The atoms are packed more densely together, more closely together. So, more chance of photoelectric effect. The higher the Z number, the chance of photoelectric effect is the cube of the Z number. So if barium has a Z number of 56, cubed, that's your probability of having a photoelectric effect, as opposed to calcium, which has a Z number of 13 cubed. So atomic number, atomic mass has a profound effect on absorption and the photoelectric effect. But we want photoelectric effect. Does it ionize the patient? Does it cause harm? Yes. But there's always some risk associated with the benefit that we get from diagnostic X-ray. Better off having photoelectric effect than Compton Scatter. Compton Scatter doesn't contribute anything to the image on your film. It just adds a layer of density. We call it fog. Okay, well, how does the patient respond to these interactions that are happening within their body? Well, it depends upon how much radiation we give them. The way that a patient responds depends upon if you give them a high dose of radiation or you give them a low dose of radiation. So you can have an early response. How many of you have ever heard of acute radiation syndrome? Hopefully it's nothing you'll ever have to experience, but in Hiroshima and Nagasaki, people suffered from an acute radiation syndrome, which is an early response to a high acute dose of radiation. Okay? So an early response would be something like nausea, vomiting, diarrhea, erythema, epilation, anemia, leukopenia. These are all things that are caused from large doses of radiation in a short period of time, and the body doesn't have time to react to it. You can also get low doses of radiation over long periods of time, like radiodermatitis, cataracts, things where you're exposed to low levels of radiation for a long period of time, and these things take years to present themselves. Okay? Skin cancer. So there's two types of responses besides late and early that we talk about, and one is called a stochastic response and the other is called a deterministic response. A deterministic response is usually a somatic effect that happens in your body in your lifetime that will happen to everyone regardless if you're given enough radiation. For example, erythema. Back in Rinken's day and up until about 1925, when they came up with the Rinken, they actually measured patients' dose by how red their skin would get. They called it the erythema dose. Okay? Now, regardless of the pigmentation of your skin or whether you're male or female, if I gave everyone 600 rads of radiation to an area of their body, it would turn red like a sunburn. At 300 rads of radiation, people that are fairer, blonde hair, blue eyes, they would get red at that point as well. So we know this will happen to everybody given a certain amount of radiation. It's already been determined. That's a deterministic effect. Now, if you expose me to 600 rads of radiation over a period of time, maybe after a while I'll develop leukemia. But maybe another person, if you look at the survivors of Hiroshima and Nagasaki, not everybody developed leukemia, although it was 3 times more common in the population. The incidence of leukemia increased 3-fold after the bombing over the normal incidence. But what about the rest of the people? What about the 66% that didn't get leukemia? Okay? This is called a stochastic effect, a genetic effect that happens, or a cancer that develops as a result of exposure is undetermined. There's a probability associated with it by your genetics, by the circumstances, or whatever. So a stochastic effect is usually with long-term late responses, and it's whether or not a person will develop a certain somatic effect. Whereas deterministic effect happens to everybody. You can tell if somebody's been exposed to radiation, how much they've been exposed to by doing a blood count. They're going to have a drop in their white blood cell count immediately after the exposure of 25 rads or more. Okay, so deterministic, these are usually the result of acute radiation exposure, happens to everybody regardless if you're given the proper amount of radiation. And the amount of radiation that it takes to produce a given effect, we call that a threshold, below which you won't see that effect. Okay, so erythema has a threshold of 300 rads. Epilation has a threshold of about 300 rads, where your hair will fall out. Cataract has a threshold of an acute exposure of radiation of about 50 rads of radiation. Okay? And then you have stochastic effects. You may be lucky enough not to get a stochastic effect, such as cancer or leukemia or a genetic effect. That's kind of hit or miss. Some people develop them and some people don't. We don't know how much radiation it takes to actually produce a stochastic effect. So we say it is a non-threshold exposure. Any amount of radiation, if you have the right genetics and the right circumstances, could cause a stochastic effect. So when you practice radiation safety, we go on the basis that any amount of radiation could be harmful. And we never want to x-ray a person unless there's a good diagnostic reason to do so, right? Unless the benefit outweighs the risk. And is there risk? Certainly. Anytime you're exposed to radiation, there's a risk of developing an effect. Now, nobody would like to see this in their patients, but this is actually a patient that was burned by a C-arm. Okay? It's estimated he got about 2,000 rads of radiation over a 5-hour period. Now, C-arms, notice the habitus of this patient. He would be, would you consider him hypersthenic, sthenic, or asthenic? Hypersthenic. Okay? He's a big guy. Now, C-arms have the ability of going into something called the boost position, or high-level radiation, where the amount of radiation given to the patient can be 4 times as great. You got a big patient like this, they're going to take more radiation. They're thicker, right? So the difference between doing a 90-pound person and a 400-pound person is the amount of mass you're going to use, right? The MA that you're going to use, because they're going to absorb more. So if you're using 90 KVP on this guy at 20 MR, milliroentgen, which is the boost position, that's as high as you can expose. Normally when we expose people to fluoroscopy, we're only giving them 4 milliroentgen per minute. This guy was getting 20 per minute. Now, it's okay to expose a person for a long period of time, but if you're going to do it, you have to change your port of entry. You can't keep radiating in the same area because the tissue is going to break down and you're going to damage the patient. Now, unfortunately, this doesn't happen overnight. This is 2 months out. Okay, and it went through a series of stages, started with erythema, and then moist discrimination and blistering, and ultimately ulceration, and then finally skin graft. But somebody's going to pay for this mistake, and it's not going to be the patient. But yes, it can be harmful if you use too much of it, if you don't know what you're doing. So hopefully by the end of this talk we won't have any problems. Now this is also an example. They used to use radiation for everything. It was the cure-all. You could actually buy pills in the mail if you had arthritis and actually take radioactive salts, radon salts, and ingest them. But they used to use it for dermatitis. They used to use it for acne. They used to use it for tinea capitis, ringworm, different types of Grin's rays, very soft radiation. But later on, people developed basal cell carcinomas and things as a result of their exposures. So when we look at the relationship between dose and effect, we say it's a linear, non-threshold relationship as far as radiation safety is concerned, that any amount of radiation can have an effect. Now, notice this is extrapolated. These effects, like I told you, we can measure erythema, we can measure epilation, we can measure drop in red blood cell count, we can measure drop in sperm cell count. Those are measured at higher doses of radiation, but it's believed that there is immeasurable damage at lower doses as well. So we assume that any amount of radiation could be harmful, and we always try to keep the dose as low as reasonably achievable. It's called the ALARA concept. to ourselves and to our patients. Now, the law of Bergonle and Tribondeau, this was way back in 1904 that they came up, the two French scientists came up with this theory before they knew a lot about X-ray, that the biological effect of X-ray was directly proportional to the maturity of the cell and inversely proportional to how often the cells reproduced. So basically, young, rapidly dividing cells are the most sensitive to radiation, and older sites that don't reproduce a lot are less sensitive or more radio-resistant. Okay? So the time that a cell is actively dividing affects whether or not it's sensitive to radiation. Why does radiation therapy work for cancer cells? Why will it kill cancer cells and spare normal cells? Cancer cells are dividing much faster than normal cells are. So if we can hit that cell during mitosis, when the DNA is doubled, and certainly, during the metaphase, the second phase of mitosis, then we can kill the cell by breaking up the DNA. And that's how they kill cancer cells. They want to radiate a patient every 24 hours to try to catch those cells during division before they can multiply. So how long the cell is dividing, and then how specialized a cell is. The difference between a grunt cell, and an erythema cell, a skin cell, and a muscle cell is one divides a lot faster than the other, right? Muscle and nerve cells don't really divide. So they're very radio-resistant, whereas skin cells divide constantly. They're very radiosensitive. Does anybody want to take a guess? What's the most radiosensitive cell in your body? I think it was on the pretest. GI's Krebs cells are very sensitive, yeah, but not the most sensitive. If you had to pick it up out of a lineup, blood cells, leukemia. Yeah, your lymphocytes, your leukocytes are the most sensitive. Why? They're dividing constantly, every 24, 48 hours. So they're the most sensitive, and actually the fastest way to tell whether somebody's been exposed to high doses of radiation. They get leukopenia. Okay, so when a cell's dividing, during metaphase actually, is the most sensitive time of, the most radiosensitive time. And what can happen to a cell if you hit it during division, and if you damage it, it can cause the cell to die. Ideally, that's what you want to happen. You don't want the cell to go on if it's mutated and divide, because then it can become malignant and cause damage. And again, this is just showing you a normal life cycle of a cell. And during the cycle, when we're out of mitosis, then the second most sensitive time for the cell is during synthesis. And synthesis is when the cell is actually duplicating all of its DNA. So this is just showing you with 500 rads of radiation, you can see during mitosis, very sensitive. This is a drop in the survivability of the cell. And again, during the stage between G1, gap 1 or growth 1, and synthesis, most sensitive time of division or of the cell. Now there's two ways that we damage cells. One is called the direct effect, and the other is called the indirect effect. The direct effect is by far less common. Only about 10 to 15% of the damage that we do to cells is by the direct effect, and that's when an X-ray photon hits the DNA of the cell. Now where is the DNA located in the cell? In the nucleus, right. The nucleus only makes up about 10% of the overall volume of the cell. So if the cell's in normal interphase, it's not dividing, it's just going about its everyday life, and the DNA is located in the nucleus, when the photon hits, the chances of hitting the nucleus are very low, because 90% of the cell is not nucleus, and the chances of hitting DNA are low. But about 10% of the time, the photons will directly interact with the DNA and interact with it and knock out part of the DNA information, which we call a point mutation. And point mutation can be very harmful to the patient. It can cause damage. These are DNA molecules after radiation therapy of cancer cells. So you can see they're not normal formation of the DNA. You've got dicentric rings and abnormal chromosomes and breakage and different things. I mean, this is good if it's a cancer cell, but it's not good if it's a normal somatic cell. So what happens is the X-ray photon breaks apart the DNA chain and knocks part of the sequencing, the genetic material, out of the chromosome. So that's 15% of the damage. Most of the time, 85 to 90% of the time, what we're doing is we're dissociating water. We break the water molecule apart. And when you break the water molecule apart, you can form something called free radicals, and those free radicals damage the DNA. So the damage is done not by hitting the DNA directly, but by free radicals damaging the DNA or causing hydrogen peroxide inside of the cell, which kills the cell. Okay? So that's a process of, this is, I mean, for those of you who are interested, the X-ray photon goes in, knocks the water molecule out. It actually causes the water molecule to become positively charged. That free electron then can ionize another water molecule. So you have two ionized molecules here. This will break apart, so the hydrogen will drop off, and this hydroxyl will become a free radical. And here the hydroxyl will come off, and the hydrogen will become the free radical. These two combine with this combines with more hydroxyl to form H2O2, which is peroxide. This combines with oxygen to form OH2, and combines with other OH2 to form H2O2 plus an oxygen molecule. But both end up resulting in hydrogen peroxide and damage to the cell. So radiolysis is the main way that we damage our cells when we're exposed to radiation, because we're mostly water. Now, the cells that are most sensitive in your body are the lymphocytes, the blood cells, and that's why you hear, the association of leukemia with high doses of radiation. There's no cancer that is specifically caused by radiation, meaning that or radiospecific, meaning that you can't get it by any other means. You can get leukemia naturally. You can develop leukemia with no exposure to radiation. Does high doses of radiation increase the incidence of leukemia? Yes. Actually increases the incidence of any type of cancer, but particularly leukemia. So high sensitive would be the lymphocytes, the spermatogonia, the erythroblast. A blast is an immature cell, so immature cells are still dividing, so they tend to be more sensitive. And then, of course, as you mentioned, the intestinal Krebs cells. We're pretty much like donuts. We have epithelial cells on the outside and the inside of our bodies, and so we're constantly reproducing those cells, more on the inside than on the outside. So when somebody gets a very, very high dose of radiation, nausea, vomiting, electrolyte imbalance is common because they damage the lining to their intestines. So they get, enteritis, inflammation. Intermediate cells, because they don't divide as rapidly, but they still are sensitive to radiation, are endothelial cells, osteoblasts, spermatotids, and fibroblasts. And then low sensitivity, or what we consider to be radio-resistant cells, would be things like your muscle cells and your nerve cells. They can tolerate more radiation than any other part of our bodies. Now, radiosensitivity is also related to age. The younger the organism is, or the individual is, the higher the sensitivity to radiation. So the most sensitive time is during development. If a woman is pregnant, if you expose her from the 2nd to the 8th week during organogenesis, this is considered to be the most radiosensitive time for the fetus. Okay? The first 2 weeks, I'm not saying it's no big deal. You don't want to expose anybody who's pregnant, but the first 2 weeks, most women don't know they're pregnant, and it's not a fetus at that point, it's a zygote. The zygote, the exposed egg, is still usually in the fallopian tube, right? Implantation, we call it pre-implantation, hasn't even taken place yet. So the chances of hitting that are very small, very remote. 25 to 50% of pregnancies result in spontaneous abortion and reabsorption. So that's only increased by about 1% if you expose a woman to 200 rads of radiation during the first 2 weeks. So it's considered, as far as pregnancy goes, relatively the safest time to expose them. But 2nd to 8th week, not a good time. So you can see in utero is the most highly sensitive, and then through childhood, when we get into our teens and our 20s and our 30s, we're most radio resistant. Then, that lovely age, 50 is the new 40, right? So when we get to be about 50 or 60, then our immune system starts to fail. We don't have the ability to repair the damage as easily, and we become a slightly more radiosensitive again, to about where we were before birth. Okay? So this is just showing the effects of 200 rads of radiation. Again, remember, a rad, when we talk about millirads, that's 1,000th of a rad. We said 10 millirads for a chest x-ray. 200 rads of radiation would be very difficult to get. You're not going to get it from any diagnostic examination. But if you were to expose a woman during the first trimester, the chances of prenatal death, of course, would be very high, drop off as the fetus develops. But congenital abnormalities because of organogenesis is the greatest risk that you're going to have as a result of that, and neonatal death. Notice leukemia. Leukemia is increased throughout the entire, the risk of leukemia is increased throughout the entire pregnancy. So I remember back in the 80s, 70s and 80s, before ultrasound really took off, we used to x-ray women for breech to see if the baby was breached, do a KUB, or sometimes be called up to labor and delivery and do a KUB on a patient that maybe was having difficulty. Now all of that's been replaced by ultrasound, right, which has no exposure to it. But anytime you expose a child or a fetus, there's an increased risk both for leukemia and later on in life for solid tumor to develop, up until about the age of 20, the latency period. Okay, so first 2 weeks of pregnancy, high exposures may cause reabsorption, but otherwise there's no likely response that we're going to see. 2nd to 8th week is a very sensitive time during organogenesis, and you want to avoid that. We always want to ask patients, is there any possibility they could be pregnant before we do a high dose exposure like fluoroscopy or a CT scan. Chest x-ray, we do x-ray women that are pregnant with chest x-rays because it's a very high KVP, very low absorption, and we can shield them with an apron when we're doing that. Okay, now I will take questions. Crystal clear. Any questions about anything that I've covered so far? And actually, I'm on time. Good. I was worried about the time. I could cover all this in 1 hour. This is the biggest section. We'll be covering other sections as well. Any questions? Do you guys need a quick break?
We have 5 or 10 minutes. Or 5
okay.
minutes, sure.
If you want to take 5 minutes, and then I'll start section number 3.